Thank you, Gene, for the introduction. I appreciate it. And what Gene didn't add is that I've been friends with him for now over probably 40 years, so that's the most important thing. Thank you for inviting me to speak here. It's a real pleasure to be here at the second meeting. The first one was great, and the second one is even better, so that's great. What I'd like to do is talk to you about carrier screening today. And while the topic is the title is Targeted versus Expanded Carrier Screening, I'll kind of take a little bit of license with that and talk about carrier screening in general. And the issues that I want to talk about today are several, and carrier screening is changing, as most of you know, and a lot of that is due to advances in new molecular technologies. So one of the things, and I think one of the most important topics I want to go over today, is ethnic versus pan-ethnic screening. That's changing, and I hope with the data that I present to you today, I'll convince you that pan-ethnic screening seems it will be a more reasonable approach to carrier screening. We'll talk a little bit about targeted genotyping versus next-generation sequencing, and then I'll also talk a little bit about design of disease panels. I know that all of you have seen there's different panels, and what I want to talk to you a little bit about is how we think about what should be on those panels, how large they should be, because I think that's important in terms of evaluating what you want to use for carrier screening. So the way I'll approach it is talk a little bit about the history of carrier screening, then talk about current guidelines for screening. And the reason for talking about current guidelines is not to really acquaint you with exactly what is done, and I'm going to focus on U.S. guidelines mainly, but to use those as a frame of reference for talking about what's going on today and what people have been thinking about versus moving forward into the future. And then we'll talk about expanded carrier screening. So history of screening, and I want to start by talking about which has really been the prototype for carrier screening, Tay-Sachs disease. It's a disease that many of you know about. Looking around the room, some of you may look old enough to actually have seen some cases of Tay-Sachs disease, but it's a disorder that really has been the model for carrier screening. And I'm going to talk a little bit about that, but I'll then talk about how that model is changing. And if you look at the bottom of the list here, the main things which made this a model for carrier screening is that it's autosomal recessive, so it has a straightforward inheritance pattern. It has a Ashkenazi Jewish predilection. 95% plus of carriers traditionally have been Ashkenazi Jewish background. With a high carrier frequency and death in 2 to 5 years of life and no treatment. And to the right is a picture of the fundus of a child with Tay-Sachs disease. And the reason that I put that up there is because this disease is becoming much less frequent. And what happens now in many instances is that blindness is part of the disorder, and when these kids start losing vision, they're taken to the ophthalmologist, and this is actually how the diagnosis is first suspected. The ophthalmologist sees the cherry red spot. And it also is a good example of what we spoke about yesterday, the issue of the diagnostic odyssey. And now people don't think about Tay-Sachs disease, so it may take quite some time to figure out what the disorder is, and especially as it's moving to other ethnic groups, and we'll talk about that. The disease was first described by Tay in 1881 and Sachs in 1887, and with the development of the description of the enzymatic defect by Okada and O'Brien in 1968, and then the O'Brien reporting that carriers of Tay-Sachs disease have intermediate levels of hexosaminidase A. That really made it amenable for screening. As many of you know now, while some serum enzyme analysis is still being done to detect carriers, much of the diagnosis of Tay-Sachs disease carriers is moving to the NGS platform. Screening programs were started by Mike Kabak in early 1970s in the Washington-Baltimore area, and with the involvement of religious leaders in organizing screening programs, there was widespread screening in the United States at that time, and that's really it has spread around the world. And so it became a real prototype for the prenatal diagnosis and screening of recessive disorders. And here's what's happened over the years. Look at the incidence on the left. You can see from the 1970s, the incidence has dropped significantly of Tay-Sachs disease. But a couple of things. You can see it has not disappeared. And if you look at the blue curve, that is the non-Jewish incidence of Tay-Sachs disease. So you can see that that has remained steady and is actually more frequent in non-Jewish individuals than in Jewish individuals now. And that looks like it may be trending up a little bit. I don't have any more recent data, but the suspicion is that is trending up a bit. So it's more likely to have a child with Tay-Sachs disease in a non-Jewish couple. We've looked at our own screening data, and what we found is that 45% of the carriers that we identified in the Jewish, what are called the Jewish genetic diseases, have not marked off any Jewish, don't report any Jewish ancestry. So another example that we're finding many carriers for what have traditionally been called Ashkenazi Jewish diseases that are not, or at least don't report any ancestry. Part of the problem is just the terminology. ACOG, American College of OBGYN, and Canadian organizations to be of Ashkenazi Jewish background, it just talks about ancestry. It doesn't talk about what that means, a grandparent, whatever, just ancestry. American College of Medical Genetics gets a little more, tries to be a little more exact, and they say one Jewish grandparent is sufficient to offer testing. However, if someone is unsure as to their precise lineage, it is recommended to offer testing. How many patients that you see are sure of their precise lineage? When I was in practice, it wasn't many. So essentially what they're recommending is almost universal screening for Tay-Sachs disease. And as you know, it's more common in French Canadians. There's a CoGEN population mutation. Also, I haven't seen good data, but many people have reported that they think the incidence is increased in the Irish population. Another disorder which people have looked at, a common disorder, cystic fibrosis, which you're all aware of, in terms of its ethnic predilection. Initially, when ACOG and ACMG talked about screening in 2001, they said it should be offered to Caucasians and Ashkenazi Jews and made available to other ethnic groups, and they recommended a 25 mutation panel. ACOG in 2011 it came out with this statement, and I think that it really is applicable to not just CF, but to other disorders. It's becoming increasingly difficult to assign a single ethnicity to individuals. It is reasonable, therefore, to offer CF carrier screening to all patients. And why they haven't extended it to other disorders yet, it's surprising. And part of the reason for that are these population statistics. These are from the U.S. 1 in 7 marriages are between spouses of different ethnicities. Multiracial children have increased 50% over the last decade. And many publications support the pitfalls of relying on self-reported ethnicity. Another issue I want to talk about, it is not related to the ethnicity issue, but talking a little bit about targeted genotyping versus full sequencing. And the example I'd like to use is cystic fibrosis. And this table is from the current ACOG technical bulletin. And if you look at the detection rates, and this is for the recommended 23 mutation panel, you can see that the detection rates vary between the different ethnic groups, from Ashkenazi Jewish populations to a 94% detection rate to Asian Americans to 49% detection rate. And the reason is and I'll show you some data about that in just a minute, but the reason is that looking at those mutations, the mutation frequencies vary among the different ethnic groups. And the implication of that is because in the Asian American group, it's much lower. The residual risk, the approximate carrier risk after a negative test result is still about 1 in 180. So when you're screening, you need to let people know about what that residual risk is if you're not picking up all or nearly all mutations in a population. And if you look at that, you could say, well, let's just do more mutations. The problem is that, at least with cystic fibrosis, you can see the number of mutations has grown, and right now there's over 2,000 mutations that have been reported to cause cystic fibrosis. So it's difficult to keep up with that if you try to just do targeted mutation testing. And we've looked at that, and what we've done is modeled the ACMG 23 mutation panel, looked at an ACMG 29 mutation panel. They've also talked about a 42 mutation panel, and then looked at next generation sequencing. And you can see that with next generation sequencing, it moves the detection rate for all ethnicities listed on the left close to 100%. If you look at the smaller 23 mutation panel in green, you can see how that varies among the ethnicities, both being quite high in Ashkenazi Jewish individuals and Northern European, but much smaller in Southeast Asian and South Asian and East Asian. And even adding extra mutations, you can see that for some ethnic groups it increases the detection rate somewhat, but for others really minimally. So there's wide variation in the mutations, and there are many, many mutations now, over 2,000, responsible for this disorder. So my argument would be that increasing mutations is very difficult, and then by next generation sequencing, where we look at all the exons, we end up having close to 100% detection rate. Another way of looking at this is the disease risk of expanded carrier screening panels. So this is weighted against the U.S. population. And you can see, looking on the left-hand side at next-generation sequencing, and the pinkish color one is just straight NGS sequencing. Now, there are some disorders which are difficult to detect or analyzed by next-generation sequencing, like cystic fibrosis, CAH by 21-hydrox caused by 21-hydroxylase deficiency, SMA, alpha thalassemia. So those typically are done by other methodologies, although we're beginning to be able to diagnose those by next-generation sequencing. If you add in those special cases, you can see how it increases the detection rate. And then adding in copy number variants, it brings you almost up to 100% for detection by NGS. Where if you look at the targeted genotyping panels, and the left one in the center group, the left one is 50 of the most common variants causing disease versus 100 versus 200 versus 500, you can see that it does increase the detection, but not by a huge amount. And looking at adding those special disorders in, again, it increases the detection rate by adding those disorders in, but you're still a maximum of just under 90% versus close to 100% with next generation sequencing. One of the other things, and I'm just going to talk for a couple of minutes about designing panels and deciding which disorders to put on the panel. This is looking at relative disease risk, percent that we see of total disorders, so it's disease, in the U.S. population. And you can see for the more common disorders, hemoglobin B, cystic fibrosis, Fragile X, that those account for a large percentage of cases. So if you can increase the detection rate in those common disorders, you end up detecting many more carriers than increasing the detection rate by a similar percentage in the much less common disorders. The other thing I want to point out, of the least common one, the 74 rest at the bottom just means the rest of the low frequency disorders. If you pool them together, they still end up being a sizable category. But the trade-off is a couple of things. First of all, as you increase the number of disorders, even though you may not have as many affecteds, you end up having more carriers and having to do more testing. The other thing that you have are more variants that you see, variants of uncertain significance and ones that you have to curate. Some tests set up what's called a white list of variants that they look at and just pass through. Our approach is to do real-time variant curation. So as we run an analysis, if we see a variant that we haven't seen before, it's curated right at the time that the test is being run. And curation means we go through a whole sequence of things, including databases, literature search, experimental evidence, computational algorithms, and feed that into software and have a whole team that will look at that and decide whether they think it's pathogenic or likely pathogenic. We don't report back any variants of uncertain significance. We think that that's inappropriate for a screening test like this. But to be able, as you add disorders, this creates a huge workload for the variant curation team. So that's one reason for trying to keep the disease panels at a reasonable size. Okay, let's talk a little bit about current guidelines. And as I said, I'm going to use those as a means of comparison to decide on, to look at screening. This is the current U.S. paradigm, and you can see that the red is American College of Medical Genetics, the blue is ACOG, and the only one which is for universal screening for both organizations is cystic fibrosis. Spinal muscular atrophy is recommended by American College of Medical Genetics, and then there's variation. But the point is, it's almost all, except for CF and spinal muscular atrophy, ethnic-based and ethnic-driven. The European guidelines have come out this past year, and it's really a review of carrier screening and expanded carrier screening. They don't make specific recommendations for disorders, but it's a very nice review of the principles of screening and some of the issues that are involved with expanded carrier screening. Okay, expanded carrier screening. It was introduced about 2010, and the principle was that we would do pan-ethnic screening of a large number of disorders. And the first panel was about 100 plus disorders, and initially started out with targeted mutation, but has moved towards full exome sequencing. And this was the first large study that was published looking at the effect of expanded carrier screening in 2013 with 23,453 individuals. And the bottom line for this study is that 70% of the carriers that were detected would have been missed by ACOG guidelines. 69% of the carriers would have been missed by ACMG guidelines. What's happened over the past number of years, and this is from our best estimates from looking at insurance data, showing the expansion of expanded carrier screening in the U.S. For 2014 numbers were about 30%, and we think now it's over 40%, extending to about probably 50% this year of people who are doing screening in the U.S. are using expanded carrier screening. Because of that, and I think it may have been at a meeting like this, Ron and I were sitting and having a beer probably, and started talking about expanded carrier screening and how there really weren't any guidelines, and there was confusion among practitioners and among laboratories about the best way to approach expanded carrier screening. So we brought together a group from 5 different organizations, ACOG, ACMG, NSGC, SMFM, and the Perinatal Quality Foundation, to try to come up with some guidelines. And what we formed was a document called Points to Consider for Expanded Carrier Screening. It was published in Obstetrics and Gynecology in March 2015. And it was a struggle to get 5 different organizations to agree on anything, much less a topic like this. But we persevered, and I think the document is helpful. And it's not really a document that looks at whether you should do expanded carrier screening. It's if you're doing expanded carrier screening, these are the points to think about. And one of the things that the document indicated in terms of a need in this area was a need for more data to facilitate general pan-ethnic screening and to determine the frequency of variants in previously untested ethnic and racial groups. So we took that to heart, and we published this paper a couple of weeks ago in JAMA, a modeled fetal risk of genetic disease identified by expanded carrier screening with an N now of 346,000 individuals. The study design was looking at self-reported ethnicity. Everyone that received screening had a checkbox on the form, so it's self-reported in 15 ethnic categories, supported by U.S. Census data. It excluded known carriers or those with a family history of a condition, and we included only severe and profound disorders. There were some mild disorders on the panel that were removed. It was a combination of targeted genotyping and NGS, which I'll show you. And all of the data that I'm going to show that's in the main body of the paper was looking at same ethnicity couples mating. But if you look at the supplement of the paper, and you don't have to read all of it, it's about 160 pages long, the online supplement. It has all the data, so you can actually look across ethnicities if you want to and calculate different ethnic mating patterns. And what we decided to use as the what we would look at as outcome, because a couple of disorders are autosomal dominant, we decided we would look at actually affected fetuses. And for example, with Fragile X, if you just look at the carrier frequency, that doesn't tell you the rate of an affected fetus. As was discussed yesterday, it depends on the size of the triplet repeat in terms of disease incidence. So we calculated that in, for example, in Fragile X, and are looking at trying to standardize that, looking at the number of affecteds per 100,000. And if you look at the bottom line here, and this is a table from the paper, you can see that of the females, about 250,000 were targeted genotyping. Next generation sequencing was about 23,000. Males, 58,000 were targeted genotyping. 15,000 were next gen sequencing. So the total for targeted genotyping was 308,000, and for next gen sequencing, 38,000. And you can see the last 5 ethnicities, or 4 ethnicities in the group, we excluded from analysis because the numbers were under about 5,000 individuals. But you can see for almost all of the other ethnicities, the numbers were quite robust. This data, some of this data is actually in the handout that was included in your registration packets. And this is just another way of looking at the distribution of different ethnic groups that we saw, with mixed or other Caucasian being about 85,000, Hispanics 29,000, 24,000, almost 24,500 Ashkenazi Jews. And these are just some of the highlights in terms of the data. You can see all of the breakdowns in the paper and in the supplement. But using guideline-based screening programs, and by what that I mean ACOG and ACMG guidelines that I showed you earlier, you miss a significant percentage of pregnancies affected by serious disorder in different ethnic groups. In East Asian, for example, you miss 94% of serious disorders by just using those guidelines. Hispanic, 79%. Northern European, which the guidelines are pretty good, you miss 65%. And Ashkenazi Jewish, even 55%. What I'd like to do is just briefly go through some comparisons of single gene diseases, just looking at the common ones that people screen for, cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome. And for looking at comparing cystic fibrosis with spinal muscular atrophy, in Europeans, the SMA risk is about 25% that of the cystic fibrosis risk. Now, that changes in other ethnic groups. In non-Europeans, SMA is about 67% of the CF risk in Hispanics, and over 1,000% of the CF risk in East Asians. So quite a difference in incidence of the different disorders. If you look at cystic fibrosis and Fragile X group and Fragile X, in every group except Northern European and mixed other, Fragile X was more common than cystic fibrosis, 1.2 times in Southern Europeans and 17 times in East Asians. Looking at spinal muscular atrophy compared to Fragile X syndrome, in every group except Southeast Asian, Fragile X was more common than spinal muscular atrophy, 1.2 times in East Asians and 7 times in Middle Eastern and Ashkenazi Jewish. This calculation we didn't do in the paper, but you can do it from the data's there. In all, about 1 in 550, looking at all ethnic groups, 1 in 550 pregnancies will be affected by a severe or profound condition on our expanded carrier panel. And just to compare that with Down syndrome incidence, open neural tube defects, and cystic fibrosis, to give you an idea of what the incidence of a severe disorder is if you use an expanded carrier panel like this. I always like to close with this quote. It's from Francis Collin, who's the director of NIH, his 2011 publication. It's interesting. What he said was, likely within a few decades, people will look back on our current circumstances with a sense of disbelief that we screen for so few conditions. Thank you.